Thank you for the invitation to be here. I think we can all agree there's been some incredible discussion so far, and I think after this AI session there will be also far more discussions that will take place. I have no conflicts of interest. So I first wanted to have a little look back at kind of where we started so we can actually see how far we've progressed. So actually back in 1960, that's when we first looked at computer-aided diagnosis of lung cancer on X-rays in the group from Ludwig. At the time, they didn't have the best results, so we didn't progress so much further at that point until really the 1990s, when we had computer-aided detection of nodules starting. And then in the 2000s, this continued to develop, and then also along with segmentation to help us measure the volume of nodules. Later in roughly 2010, that's when we started to really see an increase in AI being developed for lung nodules, and this was when the LIDC dataset was made openly available, and also the Luna 16 challenge was opened. This looked at segmentation, risk prediction, and also radiomics. Later, in 2013, we had the development of lung nodule risk prediction models, so the Brock model, for example. And then later on in 2015, and since then, actually, we're shifting to strategies of how we can implement AI and beyond computer-aided detection of nodules to looking at implementing it as a second reader or even as a first reader. So these are kind of the different ways that we can look at implementing. So we have the assistant to the radiologist, where Professor I-ELCAP also went through these in his introduction. And that's where we look at computer-aided detection, lung volume segmentation, lung nodule risk stratification. And this is where in a screening program, for example, you would have 2 radiologists, and they would be using AI software to help with these processes. The detection of nodules, this was really initially to detect those small nodules in the periphery or by the hilus that would be missed by radiologists when they were screening the scan. But one criticism with this is that it can increase the number of nodules that need to be checked. So I've seen some cases with 20 nodules detected by AI, some cases even with 70 nodules detected by AI. And of course, the majority of those aren't even clinically relevant. You also have the segmentation methods from AI. This has really helped enable the volumetric measurement, really important when we go on to follow-up nodules so that we can calculate the VDT measurement. And also then strategies which looked at predicting a nodule's risk of malignancy, so distinguishing between the benign and the malignant nodules in order to reduce false positives. And in terms of false positives, I mean those that would be referred to clinical practice, which could then later be turn out to be benign. A strategy which is we'll recognize probably from in the long run. This is AI read alongside the radiologist, both as independent readers. This would in effect replace that second radiologist read. This will help improve performance. You again decrease the number of missed nodules or the number of incorrectly classified nodules. But what you could do is increase the number of discrepancy cases which would need to be read by an expert panel. But luckily in the long run, we see actually that this is quite a small number of cases that are discrepant. And then we go on to the first read implementation method. And this is to triage some cases so that the radiologist doesn't need to read these. This would be then independently, fully automated segmentation, classification, and that you rule out all those cases which you would deem to be negative, so small nodules or no nodules on the CT scan. Yeah, the massive benefit is this, with this method is that you can reduce CT reading workload, but the risk with this method is the false negatives, so if AI misses one of the lung cancers. So I'm going to make here maybe a bit of a sweeping statement, but one that I think we should be thinking about. When we talk about implementation of AI, I think quite often we talk about what AI can't yet do. But I think we heard from a lot of presentations so far, a lot of things what AI can already do. And if we think about it, for example, in terms of detection of incidental findings, I myself look at AI as a first reader, and the first criticism that's already made or question that's always asked is, yeah, but AI can't detect incidental findings. But I think we should look at that differently. I think we heard already AI can do some of these things. AI can detect some of these incidental findings. We heard already positive results for the detection and quantification of coronary artery calcium, emphysema, but aortic aneurysm, detecting other osteoporosis and other factors. Actually, we have different AI systems that can already and are working on the detection of those things. So if we look at what it can do, we can maybe put together some solution that we work together, collaborate and put them all together and make one system that could potentially actually detect all of these incidental findings, which gives you then the opportunity to implement AI as a first reader. So talking about what AI can do, I thought I would look at some of the most recent literature from last year and early this year, what's been published. So if we look at AI for risk stratification, there was a study that came out last year from a group from the Radboud in the Netherlands, and they externally validated a deep learning algorithm, what they developed themselves. They did this in the Danish lung cancer screening trial dataset, MILE trial dataset, and the Nelson trial dataset. This was all including baseline CT scans, and they compared it to the PanCAN model. They had histological outcomes for this, and they did the analysis on 2 levels. So they looked at when they used the entire cohort of all of those different data sets, and they also looked at it when they only looked at the indeterminate nodules. So not all of the tiny nodules, but those ones which they needed, the radiologist often has to think about and stratify into whether they think they should do a follow-up or whether they should refer. What they found in the entire cohort, that there was equal performance between the PanCAN and the deep learning model, but when they looked specifically at those indeterminate nodules, the deep learning algorithm, what they developed, was superior. And they had a 39.4% relative reduction in the false positives. And then I will go on to, I actually skip over here as a second reader because I think we're all awaiting the final results of the 4 in the Lundgren. And in between 4 in the Lundgren and around 2017, there's not a lot that's really been published on AI as a second reader. But one of my colleagues, Anna Wolstra, she looked at AI as a potential first reader with the baseline data from the 4 in the Lundgren. And this was where an independent radiologist had read the scans and also AI. And it was compared to a reference standard, and the reference standard in this case was an expert panel read, and they were blinded from the individual reads. So you have this stratification based on the nodule volume, and what they found is that AI actually had less negative misclassifications. AI had 1 less misreferral case, and actually the AI errors were due to a detection error. So I think this does start to show promise as a first reader, and the histological confirmation for this will follow. But actually we already looked at whether we can validate it against histology in the UKLS data set. So we also published this research last year in collaboration with Professor Field, who's also here. We used the UKLS trial data set. We independently read it again by 3 readers, and the AI independently read it. And here we did compare to an expert reference panel, but also importantly, the lung cancer outcomes. And what we see from the results is that AI missed 2 of the lung cancer cases which were in the baseline round, but that was actually better than all of the individual human readers. Only the expert panel, who took some time to discuss the cases, they were the ones that performed the best. And what we saw when we looked carefully is that the original AI system, well, we knew it didn't have mass detection above 4 millimeters cubed. And because this was a baseline round, of course, we do have some of those large masses which are being detected. When the mass detection was enabled in a later version, there was only 1 missed lung cancer, and this wasn't due to a detection error because AI detected it and measured the volume accurately, but this was due to, during the UKLS, they had a lower threshold, so that case was referred earlier for screening, and this turned out to be adenocarcinoma in situ. And what we did from this is we looked at how many cases, how much workload you could reduce by ruling out those negative cases, and we came to around 67 to 79%. I was very pleased to see the publication from the BioMile study, who also looked at AI as a first reader. They also compared to histologically confirmed results, and their stratification was based on the lung grads. So negative category 1 and 2, and positive they categorized as 3 or 4. They had in total, if we look at the table, they actually have 63 screen-detected lung cancers, and what they saw in these was that 2 were classified as a lung grads 1 or 2, so they would have gone to biannual screening, but compared to the radiologist, they put 4 in that category. And these also estimated a workload reduction of around 75%. Briefly, AI at follow-up. My colleague is looking at this and she has a poster on this, Baby Yang. Follow-up is a lot more difficult, a lot more complex because you have to do the nodule matching and also the VDT calculation. But we saw here that when we were looking at VDT, the negative misclassifications at 3 months were the lowest for AI. And AI classified 7 of the lung cancers, what we had out of 9, actually as having a VDT shorter than 400 days. And 1 of them had a VDT of 426 days, so very close to that threshold, a borderline case. So we think it can definitely show a potential when we look at it at follow-up. But there are, of course, some challenges. And not some, actually quite a lot. Trustworthy validation is one, fear of replacement, incidental findings, responsibility, the ethics, performance standards and performance monitoring. I think that we can take some steps in this direction, but I think Agile is especially important for discussing these challenges and seeing how we can move forward. We need the accessible and the high quality imaging data sets, and we also need to be using the right reference standard. So if we're talking about lung cancer as an outcome, we need histological results. And the endpoint, so it's what you see is that if you only use the AUC, you don't really fully understand the performance of that module algorithm. Fear of replacement, this is a myth, but I think it's important that we discuss it. A lot of the time we talk about outperforming the radiologist, but actually we need the radiologist for the complex nodules. We will not be replacing radiologists, we need them. Those indeterminate and positive nodules, we need their clinical expertise and relating it to clinical practice to be able to make the best follow-up strategy for those patients. Incidental findings, we already mentioned, radiologists can detect a lot of things on CT and AI potentially also, but actually at the moment there's not really an international consensus on what we should be reporting. So I think that needs to come so that we can really determine how we can implement AI in the best way. A paper which was published 3 days ago, I think, looked at AI in healthcare and compared the US system to European and the Chinese system. Every system classifies AI as high risk, but there are quite some shared priorities. So protecting patient data, maintaining transparency and reporting, keeping the doctors in control, and also monitoring performance over time. So I think these are all areas what we can look at collectively and see how we can best approach these going forward. And then performance standard and performance monitoring. I remember from the first Agile meeting, we had a discussion on what is actually necessary, what is the gold standard for AI to be implemented. And I think at the time we weren't really sure what that would be. We had a discussion, should it be as good as best clinical practice? But I think this will be dependent on every different type of implementation strategy and setting. And also, who is responsible for monitoring the performance over time? Is that the company or is that the hospital or the healthcare system? So very short, going forward, I think we should be looking at these validation platforms, creating international standards, looking beyond lung cancer to a comprehensive screen, and also maybe expanding beyond what we currently class as screening eligible. So maybe looking at incidental pulmonary nodules and whether we can use AI to recruit those into screening. So my final slide, this was actually a question which was sent to me, I think, to think about, but I would actually like to put this out to all of you. Do we need more evidence from prospective studies, or should we now start to implement AI in screening programs like some countries are doing so far and learn about AI as we go? And I asked AI to generate an image for me to look at what AI can do compared to what it can't do, and more in a positive way. And this is what I got. Some bold statements. I'm not sure evidence-based, but I think we will all agree that early detection, better care, and more lives saved is the goal that we're all working for.